Great. Welcome to the House Healthcare. It is in here, May 9th, Tuesday, I think, Tuesday. And we have Department of Vermont Health Access with us today because the end of the federal public health emergency for COVID-19, I think the 11th, right? So I've asked them to come in and just give us an overview of how that affects Vermonters. So thank you for coming.
Thanks for having me, Madam Chair. For the record, Andrea DeLabriere, Commissioner at the Department of Vermont Health Access. And as Madam Chair mentioned, we're just going to provide an overview of what is changing, some discussion points around telehealth, and go from there. So as everyone is likely aware, states were offered some flexibilities to administer the Medicaid programs throughout the public health emergency. Mm-hmm. And then the Biden administration announced the declaration of the end of the public health emergency for most things on May 11th, 2 days from now. Some of the programs, such as redetermining Medicaid eligibility, as we know is already underway, will revert back to pre-pandemic criteria and/or funding. Ginger's running the slides. Great. My laptop needed an update. So when we talk about some of the things that are being extended, one of those is COVID cost sharing. So any treatment or prevention for COVID-related services such as vaccines, testing, and pharmaceuticals would be continued without cost sharing for Medicaid members through September 30th of 2024.
And that's a federal across the country, not just Vermont. Okay, great.
Correct. Yep. I'll try to stay with you. And when we talk about telehealth changes, so interesting, many of you may already know this, but before the public health emergency, Vermont Medicaid did not cover audio-only services for telehealth-related activities. But under the flexibilities offered during the public health emergency, Vermont Medicaid did cover audio only, as well as audiovisual, which we had already covered, and we paid parity for those services. The
parity to an in-person.
In-person, audiovisual, and audio only are all covered at the same rate currently. Codes that, one update is important, codes that are disallowed for audio only services, that's per federal government regulations, won't be covered any longer as of July 1st of this year. So there are some codes, such as an example of that would be a new patient in-person visit, for example, where that flexibility was offered during the public health emergency to be covered via telehealth will no longer be covered after July 1. We, as the department, have made a policy decision to extend coverage for audio only and parity through, for the correct coding aspects through December 31st of 2024. So part of the reason for that is we really want to make a data-informed decision, and it takes a little time to understand what's really happening with these services, which we'll get into a little more in the next few slides.
So, and I want to be clear, it's 2024, not 2023.
Correct.
So great. Okay. Thank you.
Related to some of the DEA rules being considered for prescribing controlled substances, I think that things are still being developed in that area. I know they have received a number of comments, so I'm not exactly sure where those will land, but Medicaid will follow their guidance in that area. And then the other item for those HIPAA compliant connections, those were actually waived during the health emergency, and those are ending. So at the end, on May 11th, we will now require, I don't think we ever really had many instances of non-compliant HIPAA or HIPAA non-compliant connections for telehealth related activities, but we will not honor those in the future if there were any.
So can I ask a question on that? So let's say it's audio only, so you're talking to someone on the phone. How does HIPAA compliant connections work for that?
That I don't know the answer to. I think it would be difficult. I mean, we assume that phone lines are secure,
right?
If they are not party lines or you're not merging a call,
right? Okay.
But beyond the individual connections, I don't know that there is one. I think they're more considering these for audio visual connections than they were for audio only.
To that same question, What makes one visual more HIPAA compliant than another?
I think if I use the store and forward example, that's probably the most relevant, where if I'm taking a photo of a sore that I have on my arm and I would like a physician to look at it and I can't get to the office during a public health emergency, I can do that. I can send the photo to the individual, but that person can look at it at any point in time. So that provision, I believe, will be ending, and part of the, I'm going to turn to Ginger as the, my phone a friend, but those will no longer be honored because it would not be considered a secure connection from one individual to another, because anybody could look at that photo or anybody could send it. We don't know if it's from the individual or not. Does that make sense?
Yes,
Sort of.
it does.
Could you do it
I'm
through,
just thinking that happened before, though.
could you do it through my chart?
My chart, I believe, would be any EHR.
HR would be considered, okay.
Yep, secure traveling through one end to end. It's one point to one point. And did I miss anything, Ginger? No. Okay.
So I'm still confused about that because you can, my chart, it would be store and forward, because if I'm sending an image through my chart, it's not, the provider's not going to see it immediately. They're going to look at it later.
Right, and that's still allowed.
That's HIPAA compliant, those
Right.
EMRs.
EHRs would be compliant with the Privacy Act.
But texting a photo or emailing a photo is not. It's just the language here is confusing me because the language makes it look like the waiver ends, including store and forward. Allowed a waiver of HIPAA compliant, which my chart is HIPAA compliant, but the waiver ends, including HIPAA compliant store and forward. That's how I read it.
I understand why you're confused. That's not the intent.
Okay. Okay.
Yeah, so Vermont Medicaid will require HIPAA compliant connections going forward, and my chart is HIPAA compliant.
Things that are considered
Right.
HIPAA
That's just
compliant
one
would
example.
still be, but I would say, I think loosely, what was happening during the pandemic was probably a little different. People were moving outside the EHRs and using cell phones and other ways to communicate. And not that they don't do that also.
Alyssa and then Daisy.
To that point, why is talking on the phone audio only? The doctor's on their cell phone, you're on your cell phone. That's HIPAA compliant, but FaceTime or doing a Zoom through each other's cell phone, why would that not be HIPAA compliant?
Those are good questions. I mean, I think some of this, we can get a little more detail for you and get back to you if that's helpful, because I'm not aware of so from an audio only perspective, the other option would be to stop serving individuals via audio only. Assuming that these are still going to be considered HIPAA compliant, we want to continue to offer that service. So let's follow up.
Yeah, I think
Probably the best.
a little bit more granularity will be good because we want to make sure that telehealth is still an option. And so let's figure out how that would work.
Sure.
Daisy and then Leslie.
I do remember back in, I think it was 2019 or 2020, Nissa James was working around this. And the I think key of this is that third line under the second bullet is the guidance regarding enforcement discretion. So remember there was the ability to have some waiver in the connections or the HIPAA compliance in them, and that there was state authority granted to kind of use some discretion around how we did that. I don't know if that's helpful, but I think if we went back to when we were kind of looking at that in 2020, wasn't it Nissa who was working on this?
I wasn't here at that time, but I believe it was.
I think
Nissa.
that's where the conversations were.
And I think the question is when that waiver ends, that now what happens? Do we revert to previous?
Yeah.
Yeah. So we'll get some more information on that. Leslie?
I'm just wondering how you know whether it's HIPAA compliant or not.
How we know.
You, like you, not you. Yeah, like,
How do you know?
yeah. How does your system know?
How does that?
I'm just,
So those are codes that are billed via claims.
okay, so they'll pick a code that's HIPAA compliant or not HIPAA compliant?
Boy, this is super deep in the details.
No, but it's just confusing to me about as we go
Sure.
forward, because I really want to support telehealth and I think it's important. So I was just trying to understand how you might know it was or wasn't compliant.
So I think what we can do is
I just wanted to add that on to
for
your.
the, when we're back in session, when we will be taking up telehealth when we're back.
Great. Thanks, Ginger. Okay, so future, are we up for future? We are, well, thank you. So we have been collaborating with healthcare association leaders, including Vermont Medical Society, on telehealth coverage and what that looks like moving forward. We're really looking carefully at services to ensure they make sense, and that whether or not we determine to pay the same amount for each, whether that's audio only, audio visual, as opposed to, or as compared to in-person visits. As I mentioned before, we really want to use data to inform those decisions instead of determining that ahead of time, which is why we've extended the date through December of 2024. And that we will also ensure that the codes we cover are medically necessary and clinically appropriate, because not everything, as we know, is clinically appropriate for over-the-phone conversations.
And sorry if I can just interrupt real quick, just so everyone knows too, Act 6, I think of 2021, it was 2021 or 2022, probably 2021, requires VPQHC to come back with a report this December of 2023 about what's happened with, everyone Act 6 required everyone to set up the same codes for tracking purposes on telehealth, so all the insurers, Medicaid, and then everyone's working together, and VPQHC is also coming back with a report in December. So that's why I say, one, it's a passion of mine is telehealth, but two, we'll have some reporting coming back. So we'll be looking at this in January. Art?
Yeah. This addresses audio only. You have video only telehealth now, don't you?
We have audio, video, yeah.
Audio, video.
Yeah, so you could technically turn your
approve
camera
that.
off and still
Yes.
have.
Correct?
did, yeah.
Right. Okay, so you're talking about just for audio.
Yeah, so if you remember before COVID,
Yeah.
we passed legislation out of the House that set up a telehealth expansion. And it was to sunset in 2026, and it put a lot of rules in place. And then COVID hit and everyone said, great, what we thought was going to take 5 years took about 2 months to set up telehealth throughout the state of Vermont. And then I think there was another bill we passed that then said, okay, everyone needs to use the same codes so we can really understand what's happening with telehealth. That's everything that we'll be coming back to.
Okay.
Okay, talk about data, talk about utilization, which is always interesting. So if we start with the audio only, these are percentages of all claims. So in 2020, remember this was the first year that we offered audio only, 0.63% of all claims were utilized by audio only telehealth. The height of this was in 2021, which is not surprising, right? It does align with the inability for folks to see the physician, the more comfort levels they had with being on the phone. And then we started to see it decline again, and it has further declined in 2023 to 0.67% of all claims.
Yet you're still paying at parity.
Correct. So in terms of, yeah, it's interesting to look at the data. Go ahead.
Yeah.
Yes, go ahead.
So I'm just wondering about the people that need it and not wanting to lose track of why who that 0.67 is. Is it rural? What do they have access to broadband? Those kinds of questions. So I don't know if you can kind of, when you drill into it, think about that.
Absolutely. That's a little more about that coming up.
Okay.
And so from an audio visual perspective, we saw the height again in 2021, more folks using it. Not great uptick in 2020, but we saw, not a huge decline in 2022, and then further decline in 2023. This is all fiscal year to date, by the way. And then when we look at all other claims, that's all in-person visits. 97% of them are happening in 2020. It ticked down to 91, back up a little bit, and further back up in 2023 to 94.62. So we don't know what's going to happen this next year, which is why we really want to take some time to collect data.
Go ahead.
2.18% in 2020
Correct. Or audio visual.
for audiovisual?
Didn't have a lot of uptake.
And even in 2021, 6.86 seems small.
But the pandemic was March of 2020 and everything stopped.
Including visits.
I was gonna say, I think people
I
stopped
just-
getting Ginger.
Everyone just stayed home.
Ginger?
Ginger Irish Department of Health Access, just keep in mind this is state fiscal year.
Oh,
So
okay.
2020 is.
okay.
Right.
July.
19 for 30.
2020.
right. So our timeframe of COVID would just be March to June.
Right.
And then it goes into the 2021 number, which was a huge uptick.
Great point.
Were there billing codes then? Were there modifiers that were being used at the beginning, or wasn't it just at the very beginning?
That's my understanding. Once you understand something different, that's how we were able to track this data.
Okay.
When we talk about some of the decision-making criteria, to your point, Representative Goldman, the customer satisfaction and feedback is going to be really important to understand how they were utilizing those services, whether or not they have broadband access. Was that in addition to an in-person visit or in place of an in-person visit? Those are the questions we don't know the answers to, but we'd like to find that out. And we have a couple of surveys ready to go. One of those is the CAPS survey in the fall. And really kind of looking at codes that would violate any of the correct coding rules would be ineligible. I mean, it's just codes that require a face-to-face visit are not negotiable. When we think about whether Medicare is covering those codes, that is also a consideration for us. So we'd like to align with Medicare, as everyone here knows, where we can. But is it also clinically appropriate to deliver those services via telehealth? And we have clinicians looking at that information and collaborating with others.
In your survey, are you also asking about it was set up to be audio visual, but then because of connections, it went to audio only or something happening?
That's an interesting point. We've thought about it from the perspective of if an individual has a visit scheduled in person and something happens to their transportation, then, but I don't know that we've thought about it, but we should take a note and consider how that would look in a questionnaire.
Yeah, I know it might be hard to capture, but I know with my in-laws, most of their audio visual have turned into audio only because of technical.
Broadband access or technical issues, which happen to all of us, even now. So it is nice to have an alternative. Okay, and then when we talk about notice timing, I know this has been a topic of discussion in the past. Federal guidelines require us to give 1 day notice. Again, we try not to only offer 1 day notice, but it is sometimes up against the wire depending on what's happening and when changes need to be implemented. So we are working hard to we try to do 30 days is what we try to do, but not always hitting the mark, as we know. So happy to open it up for further discussion, though. That's where we are.
I know I didn't ask for this, so I understand if you can't provide it, but can you share how the renewals are going?
So we don't have a lot to share, but they are underway. My understanding is that we are receiving responses, which means we're reaching people.
Okay.
And that is really good. So I think it's a little bit early to say things are really going, but
Because it just started in April, right?
April, right?
So the process is you're trying to reach out to people mostly via mail and having them call, or are you reaching out via phone
There
too?
are multiple
Modalities. One of them is our methods. One of them is by text. Another is by mail. And so definitely receiving, the white envelope with the red stripe is certainly well recognized.
Yeah.
And I think that was a very good way to go about seeing people. Are you aware of any other feedback?
Yeah, I would just add that we also do email as another way to reach folks. I believe that most folks are responding,
Okay.
which is good.
Yeah, I think the texting platform has also been really successful because most folks have cell phones.
Daisy, Leslie, then Mari.
And Alyssa has
And
her hand.
Alyssa, because I never looked that way.
Can you repeat the date of the, like the final date of the timeline?
May 11th?
May
Are
11th.
you talking about the final date of the
Yeah.
public health emergency? Yes, May 11th.
May 11th.
Days from now. And the Medicaid redeterminations were uncoupled from the declaration of the end of the public health emergency, though that's why those began in April.
And you're taking up to 14 months to do it, right?
12 to 14 months, yep.
Do you have any benchmarking in terms of when to reach out to people? Is there any strategy for outreach and sort of contacting folks that you've planned?
There's a very comprehensive plan about when those individuals might be up for redetermination and then reaching out to them prior to that. They also get another chance if we don't hear from them to respond.
Would you share that plan with us?
I believe we have shared it. We have definitely have shared the link, which is the website.
Yeah.
We can reshare it if that's helpful. It should all be available.
Thanks for your work on that.
Oh, the team deserves all the credit. They did amazing. They're doing an amazing job.
Leslie?
I was curious, we talked about how difficult or stressful it might be for your team to have to do this. And now you're a month in, not much, I get it, but how's it going? How's it feel?
I think a lot. It feels like a lot. Yeah. I think that so this week is Public Service Recognition Week for state government. And we are really ensuring that we're recognizing folks as best we can and keeping morale up and encouraging folks to come out for, an hour at lunch tomorrow, I think, to have, a little bit of downtime. So I think it's going as well as it can. I think it's a marathon.
And you're at mile 2.
We're at mile like point, or point 1. But yeah, so thanks for asking. It's definitely a lot, but I think that everyone is trying to do the right thing and make sure wherever we can that folks are transferred or be able to transition to a qualified health plan wherever possible. That they stay insured or keep their Medicaid eligibility current.
Can I ask a follow-up? So given all that energy going in this direction, do you think that you need to take a pause on moving forward with other issues around Medicaid?
That's a really good question. I think that we have responsibilities. We will always have the same responsibilities. And we're fortunate to have a really talented team, and they all have their roles and responsibilities lined up for them. So I don't think that we're only doing Medicaid redeterminations. I think we continue to do the IT project work. We continue to do the rate increase or update work. We continue to look at equity and how, both members and providers can improve access to services. So all of those things are just always top of mind.
That's good to know.
Try not to neglect. And
We have some bills on our wall, but we don't want to overwhelm you. So trying to balance that.
thank you.
Yeah,
And they're all really important.
that's right.
Mari?
I don't feel like you have to answer this if you can't. It's coming from constituents, and realize that DIVA may not be the right tree to bark up. That's a metaphor I could use. But it's about masking and the concern they have about the change in general around masking requirements, especially in hospitals. And I wonder, are you aware of any the administration being involved in any conversations with stakeholders about masking?
I'm not aware of that. We wouldn't necessarily be asked though.
That's what I.
Yeah. Yeah. I'm trying to think of who the right BDH perhaps. Yes, right. That's BDH. Department of Health. They do provide the guidance.
Back to the question of information, if you go to diva.vermont.gov, there's quite a bit of information about the process. So I suggest people go there. There's a big thing at the top that says Medicaid renewals restart. Click on that, it takes you to a whole section. I'm wondering if we could get an update in like August or September, just sent to me as the chair, and I'll send it out to everyone of just how things are going with the renewals. I think that would be really helpful.
Yeah, happy to do that.
Okay, great, thank you. Any other questions for Andrea?
Ready to go home?
We are.
Can you tell?
You're ready to have us be home, right?
Having a lot to do.
We're reading that as get out of here. I'm kidding.
Well, thank you very much for coming in. I appreciate the update, and we'll look forward to talking about telehealth next year.
Yeah, thank you. Thanks for all your work.
Thank you. Thanks.